Good afternoon, everyone. It's 4 o'clock, the 10th of September, 2025, and it's time for the ERN webinar series. Welcome, everyone. Let me introduce myself. My name is Olga from the Czech Republic. I am an ERN Reconnect patient advocate. I am a chair of the Czech myositis working group, and I am a patient. I would like to open this webinar with the title Exercise in Adult Idiopathic Inflammatory Myopathies. The topic is extremely important for patients with myositis because our muscles are ill and they need to be strengthened to maintain physical fitness. It's my pleasure to introduce and welcome today's speakers. The first one is Professor Ingrid Lundberg, ERN Reconnect Disease Coordinator, Professor of Rheumatology at the Division of Rheumatology Department of Medicine, Karolinska Institutet, and a Senior Consultant in Rheumatology, Karolinska University Hospital, Stockholm, Sweden. She is a world-known expert in myositis. I would like to introduce and welcome the second speaker, Louise. Its ERN Reconnect Patient Partnership Representative, is a member of Disease Working Group. She is an assistant professor, is consultant rheumatologist at the Department of Rheumatology, Copenhagen University Hospital, Denmark. And of course, I would like to introduce the third speaker. It's Helene Alexanderson, representative of physical therapists in the Karolinska ERN Reconnect team. She is associate professor, physical therapist in the Karolinska University Hospital and Karolinska Institutet, Stockholm, Sweden. Helene is a world-leading expert on the importance of the physical exercise in myositis. The webinar will be recorded and published on the ERN Reconnect website and on YouTube channel. For questions during webinar, use Q&A session or the chat in the options in the platform on Zoom. Questions will be addressed to speakers after the presentation. Just now, I would like to give the floor to Ingrid. Ingrid, the floor is yours.
Thank you so much, Olga, for your kind introduction for this exciting webinar. And I have then been given the task to give a brief introduction to the topic of inflammatory myopathies, or as we briefly call this disorder, myositis. Next, please. So the inflammatory myopathies or myositis, the clinical characteristics of this disease is major involvement of skeletal muscle with muscle weakness and low muscle endurance. And typically in the microscope, you find inflammatory infiltrates in the muscle tissue. Next. But over the past years, it's been more and more recognized that myositis is not only a muscle disease, but clearly inflammatory systemic disease, also affecting skin with a rash, but also often the lungs with interstitial lung disease, the joints with arthritis, and even the heart, which is a muscle, which is, however, less frequently involved. Next, please. So it's a heterogeneous condition. Next, please. And we have, based on the clinical and histopathological features, and now also from antibodies, been able to subgroup the patients. The old subgrouping, including patients with dermatomyositis with a skin rash, polymyositis without skin rash, inclusion body myositis with typical clinical phenotype and histopathological changes. It's also known for a long time that myositis can be associated with an underlying cancer, We have a juvenile onset myositis, and more recently, thanks to the identification of autoantibodies, we have identified new subgroups called antisynthetase syndrome, also with affecting the lung, and the clinical amyopathic dermatomyositis, where the skin is predominating and the patients may have no or little muscle weakness. And then the immune-mediated necrotizing myopathy with a often severe muscle weakness. And then we also have a group we call seronegative with non yet identified autoantibodies. Next, please. So the overall goal of treatment of patients with myositis is to improve function and health-related quality of life. And we want to eliminate the inflammation, to prevent damage, and importantly, restore muscle strength and endurance. But in some patients, it may also be the goal to restore lung function, in others to eliminate skin rash or arthritis. Next, please. So there are very few randomized controlled trials to guide us in treatment decision in the clinic. So expert opinion have come up with different suggestions, and here I present one that was published now some years back by Dr. Odis and Agavar from Pittsburgh in the US. And these experts recommend as a first-line therapy glucocorticoids in combination with immunosuppressive drug like methotrexate or azathioprine. If patients don't improve with this therapy or don't tolerate, then we can change the methotrexate or azathioprine to mycophenolate mofetyl, tacrolimus, or cyclosporin. Or there is also possibility to combine methotrexate and azathioprine, but in lower doses than for each individual drug. And if this second line doesn't work, then we have more newer therapies, biologic therapies, rituximab, but also the old cyclophosphamide and other biological agents like abatacept. As you can see on all levels, first, second, and third line therapy, there is a possibility to use IVIG in patients with special clinical features and diagnosis. So next. So with this regimen, unfortunately, very few patients recovered their former muscle strength, and most patients have persisting weakness, and the muscle are easily fatigued, and patients often have a low quality of life. Patients with myositis also have an increased mortality rate compared to the general population. So we face disease where we really need improved treatment, and one possibility is what we are going to discuss today. So with this, I think we take the next slide and move over to Dr. Diederichsen. Thank you.
Thank you. So as Professor Ingrid Lundberg just mentioned, we need improved treatment to manage impaired muscle function in these myositis patients, not instead of immunosuppressive treatment, but as complementary non-pharmacological treatment. And more specifically, we need physical exercise to counteract the impaired muscle function in these patients. But what's the evidence of physical exercise in myositis? And that's what I will talk a little bit more about. Just a minute, I have to change this. So the effect of exercise is well known, and with a lot of knowledge in the general population, we know that physical exercise or physical activity will increase muscle strength, and that's indicated by the green arrow. It will increase muscle endurance as well, functional capacity, and aerobic capacity as well. And in addition, there are other beneficial effects of exercise in the general population. We know that there are physical activity increased mental health, indicated by the green area, and sleep quality, and it decreased, indicated by the red area, the risk of cancers, and any cancers, and diabetes and hypertension, which is some of the most common traditional risk factors of cardiovascular disease. And finally, but most importantly, all-cause mortality and especially cardiovascular mortality as well. So what's not to like about exercise in general? And before moving on, I think it's important to define exercise. The definition of exercise is a form of physical activity that involves planned, structured, and repetitive bodily movement performed to improve or maintain one or more components of physical fitness. And this physical or exercise therapy can be divided into two main categories, and that's endurance exercise, which is aerobic exercise, and is designed to improve cardiovascular endurance and primarily using oxygen to meet energy demands during exercise, and that's aerobic glycolysis. And common examples are running, biking, walking if it's fast, at least, but also swimming, dancing, rowing, fitness classes, and so on. And then we have the other main category, and that's resistance or strength exercise. And that's anaerobic exercise, and is designed to increase muscle strength, endurance, muscle mass, which is all the problems our patients have, primarily using stored ATP, PC, and anaerobic glycolysis, and that's produce lactate, and that's what you feel when you really do heavy resistance exercise. And examples are weightlifting. It could be free weights, body weights, resistance bands, and weight machines. Of course, there's no such thing as strictly endurance exercise or strictly resistance or strength exercise. There's a minor overlap between the two. If you're running, there will be a minor component of resistance or strength exercise as well, and vice versa. So based on the current evidence of the beneficial effects of physical activity and exercise, the World Health Organization established some recommendations on physical activity, and this is for adults between 18 and 64 years. And that is 2.5 to 5 hours of moderate intensity aerobic physical activity weekly, or 1 to 2.5 hours of high intensity aerobic physical activity, and muscle strengthening activities of moderate to greater intensity that involves all major muscle groups more than 2 days weekly, and that's strength exercise. So that was the evidence and recommendations for the general population, but what's the evidence of exercise interventions in myositis? Solely looking at randomized control trials, we have quite a lot, I think, spanning from late 90s and up to today. They can be divided into groups, endurance exercise or resistance exercise training in myositis, in different subtypes of myositis, endurance exercise and resistance training in different subtypes of myositis, and that's polymyositis and dermatomyositis. And finally, I made a category of endurance exercise and resistance training for a specific subgroup of patients, and that's inclusion body myositis, which unfortunately are resistant to medical treatment. And it's not within the scope of this webinar to go through all of these. It would take quite a while. So I will dive further into one of them, and that's the one marked with red. And that is this one. It's and why I picked this one in contrast to other subtypes of myositis. As mentioned, patients with inclusion body myositis are resistant to immunosuppressive treatment in general, and that means that the disease just progresses over time, ultimately leading to severe impairment and disability. And many patients are wheelchair bound after 7 or 10 years of disease. So that was a motivation for this study. And we included 22 patients with established inclusion body myositis. It's in Denmark, and a single center study. The patients were randomized into 2 groups. Group 1, who did 12 weeks of blood flow restricted strength training twice weekly. I will come back to that, but this specific training form. And group 2 did no exercise at all. That was a control group. And the exercising group did leg press, just common strength exercises at leg press, knee extension, knee flexion, calf raise, and dorsal foot flexion. That's the only one specific for IBM patients. So, and what's blood flow restricted exercise? It's a specific sort of exercise. You do strength training, and at the same time, you will place a cuff around the exercising leg before exercising. You will place this cuff around, inflatable cuff around the exercising limb. It's inflating during exercise, and the pressure is maintained by this pressure device. This is a really old one we used in this study, but it worked to monitor and maintain precise occlusion pressure during exercise. And this occlusion, it's not completely occlusion, of course, but it's a sort of partial occlusion, and this creates ischemia, and ischemia is extremely stimulating for gaining muscle mass. So that was the motivation. I think it's notable that there's no significant difference between heavy or light resistance exercise when you do BFR training, and that's why this specific method is attractive to IBM patients, who are weak and not able to do heavy resistance training. So they're able to do this. And endpoint outcomes were measured at baseline, and then this is typo because it was after the exercise at week 12 and not 17. And primary outcome was quality of life. Secondary outcome was physical function test, just classic ones, 2 minutes walk test, timed up and go, and 30-second chair stand. And a PROM, a patient-reported function scale, and it's called Inclusion Body Myositis Functional Rating Scale. I think that Helene Alexanderson will talk more about that one. And knee extensive muscle strength. Exploratory outcomes were muscle biopsies. And our results, we found that leg muscle strength decreased in the control group, and that was not surprising because that's the way it goes without treatment. But it was maintained. The muscle strength was maintained in the BFR group with significant between group difference, and no medication has showed that until now. And there was a between group difference in the self-reported function as well in the IBM-FRS in favor of the BFR group, but no effect on our primary outcome, that was quality of life, or physical function tests as well. And finally, and very important, the BFR training was safe, even though we included everyone with diabetes, with heart problems. There was no side effects. So my last slide. There are different sort of equipments for BFR exercise if you should want to. This is just Googled. There are many different types, and some fitness centers are specialized in BFR exercise, and that varies across regions and even in countries as well. In Denmark, we have some specific fitness centers specialized in this. But I have to warn you, you need professional instructions before doing BFR exercise. And with this advice, I will give the words to Professor Helene Alexanderson.
Thank you so much, Dr. Diederichsen. I'm very happy to be here with you today to talk a little bit about the more clinical part of getting started and continue with exercise. Next. So I'm going to go over a little bit what's important to talk to the patient about before starting exercise, what information is essential. I'm also going to talk a little bit about how we can assess using simple standardized functional tests. And I will also talk a little bit about how you can set an exercise dose, as well as what do we need to support our patients to continue to have a physical active lifestyle. Next. So I think it's important to have a careful conversation with the patient about how they are limited, what symptoms they have, how are they limited in the muscles, with dyspnea, pain, fatigue, what about the balance? It's important to know about possible comorbidities, and also to ask if your patient is physically active now and how often, and penetrate that really carefully. How many times per week? Do they get shortness of breath or become tired? How are they feeling during exercise and physical activity? And if your patient is not physically active, try to discuss a little bit. Have you tried? How was it? How was your experience? What could motivate you to get started? And are there any activities that you might find enjoyable and that you like to do? And also ask about their experience of pain and fatigue in general, but also in relation to physical activity or physical inactivity. And discuss the World Health Organization recommendations for physical activity with health benefits, and also discuss what are the risks of not being physically active. Next, please. So the one key question is to ask your patient is, what did you do in terms of exercise and physical activity before onset of myositis? Research in RA has shown that that previous physical activity habits is the most important predictor of a physically active lifestyle living with RA. And I think this is probably true for all chronic disease. So patients who have never been physically active before need lots of support to change their lifestyle. Next, please. So what important information could you give your patient? And this is directed to non-IBM myositis. It's important to get started with exercise early in disease course, already at time of diagnosis. As an adjuvant to medication that is tolerated and effective, you can expect from exercise to improve muscle function, aerobic capacity, quality of life, and possibly also fatigue and pain. And when disease is stable, the exercise recommendations does not differ much from recommendations for a healthy population. Next. And this is some additional information that can be important to talk about with people with IBM. So it seems that today, as Dr. Diederichsen said, that exercise seems to be the most effective treatment of today to counteract progression of the muscle weakness. And it's important to start exercise early in the disease course. So the more healthy muscle tissue you have left, the better expectancy you would have to improve from exercise. And from my experience, most patients tolerate exercise well. And most people do experience some positive small changes in muscle function or physical capacity, but mainly can experience a prolonged independence in activities of daily living. A few patients seem to respond very well to strength training, and they can improve and sustain a good function over many years, and they tolerate a very high dose of exercise. There are also few individuals who do not seem to tolerate exercise so well. They might experience increased muscle weakness, fall frequency, and pain. And the problem today is that we don't have biomarkers or predictors who can tell us beforehand who will benefit and tolerate exercise well. So we just everyone needs to get started, and we start on the low level and then increase and try to find each individual's optimal dose. Thank you. Next. I won't spend lots of time on this slide. It goes over mainly the same thing that Dr. Diederichsen talked about. What I could add here is that if we can achieve these recommendations, we know that you have a reduced risk of cardiovascular disease, type 2 diabetes, cancer. We can actually optimize our health, although living with a chronic disease. And I could also add that minimize sedentary time is important with health benefits. And also, it is important for many people with myositis, with muscle weakness, to also train their balance. Next, please. So, if possible, get started under supervision of an experienced physical therapist. So a physio can help you to find optimal initial exercise dose, follow up, and assess how your muscle function and physical fitness is changing over time and help you to progress your exercise dose. We can support you to manage exercise more independently, and it's important to have a contact over a long time in case you need to change your exercise habits if you're in a flare, or maybe you need some motivational support. Next, please. So we use some tools to assess physical fitness. It's not enough to only assess the manual muscle test assessing isometric strength. It's also important to include a measure of muscle endurance. For example, the functional index 3, which assesses number of repetition a patient can do in shoulder, neck flexion, and hip flexion. The 6-minute walking test can be important for people with lung involvement, where you can measure the distance a patient can walk and also monitor saturation and heart rate. Time stance test is a very easy, quick test. You ask the patient to sit down, stand up and sit down 10 times as fast as possible. I think it's very important to also assess aerobic capacity using submaximal tests, as aerobic capacity tightly connected to cardiovascular health. It can also be important to assess balance, breathing pattern, breathing muscle function. Next, please. And there are several patient-reported outcomes that are important. The OMERACT myositis working group have recently validated 3 questionnaires: pain interference, PROMIS fatigue, and PROMIS physical function, to assess these very relevant domains for patients. And we use the SF36, for example, to assess quality of life. And we know that the mental health domain there correlates well to the hospital anxiety depression scale, looking at anxiety and depression. Next, please. These are some functional tests that are useful and sensitive to change in people with IBM. So the 30-second or 60-second chair stand test, you ask the patient to stand up as many times as they can in 30 or 60 seconds. And I would also say that a 2-minute or 6-minute walking tests are important and sensitive to change after exercise in people with IBM. And of course, the inclusion body myositis functional rating scale was it was a consensus on a European neuromuscular center conference that include this IBM FRS should be the primary outcome in clinical trials. Next, please. So you can help the fit variables can help you to set an exercise dose. The F stands for frequency, how many times per week. Intensity means percent of maximal strength or percent of maximal aerobic fitness, the time for each session, and what type of exercise. So it's important to start on a lower intensity, maybe with severe fatigue and pain and muscle weakness. You can divide your exercise program in 2 parts. It's important to have variation in your exercise so you don't get stuck with the same program for a very long time. Pain levels can increase when you start exercise, but usually they go down after a couple of weeks, and muscle soreness after exercise is expected. It's a good thing. It's a kind of a stamp, quality stamp that you've done something good for your muscles. And it's important to set goals that should be specific, measurable, attainable, relevant, and time-bound. And also it's important to find activities that you enjoy doing. Next, please. So you can use different types of exertion scales to help set the correct exercise dose for a patient. So on the left side, you see a scale, a symptom scale for muscle exertion, dyspnea, or pain, where no indicates no symptoms and 10 indicates very strong, almost maximal symptom. So in the red box, you can see if you have a patient with a very high disease activity, severe pain, fatigue, ILD, for example, then you start on number of repetitions and activities that produce very light to light exertion. And then you can progress to light to moderate and moderate to strong if your patient is doing really well. And there is no end point here, so you can go down to even a 7, very strong or heavy exertion. Next, please. And to summarize, individually adapted exercise is safe for everyone with adult IIM. And exercise improves physical and psychological health and might reduce cardiovascular risk. Exercise can help sustain muscle strength and function in patients with IBM, and initiate exercise on a lower intensity and increase over weeks using the fit variables. Thoroughly investigate patients' prior and current physical activity levels, their preferences and experience during and after exercise, and use validated and standardized assessment tools to follow up. Thank you.
Just now it's time for questions. Thank you very much, Ingrid, Louise, and Helene for very important sentences and very important speech. Just now I will read the first question. Speaking about older patients with myositis, in which percentage you can find an associated sarcopenic condition that may make the clinical picture more severe, and how approach the patient in such combined status?
I don't know if we have any answer to that. I think it's really not known. We know that sarcopenia is common in people at higher age, but also in people with different inflammatory condition like rheumatoid arthritis. I haven't seen any investigations on this for myositis. I have to turn to Louise and Helene if they have any information on sarcopenia, and also whether that, I don't think that would change the intervention with exercise, but Louise and Helene, what do you say?
Well, yeah, it's really a good question, and we have asked my group. We have asked ourselves that question, and we are coming up with a study now. We have the results, and we are trying to finalize the paper. So hopefully within this year it will be published. So, and that's about sarcopenia, and not surprisingly, especially IBM patients have severe sarcopenia.
I talk to patients about sarcopenia because I think it can be one motivational factor, saying that the muscles are aging. It's a normal process. But if you also have a muscle disease with muscle weakness, then it's like even more important to train the muscles to really counteract the normal muscle aging, as well as the changes that you have with your myositis.
Thank you very much for these answers. And the second question is for Helene. Do you consider, in addition to the medical history, the kind of diet of the patient when they start the exercise program? Do you suggested drinking more water and or integrate with calcium, vitamins, and healthy diet? No alcohol, less fat food, red meat, etc.
Thank you. I think that's a very interesting question, a very important to eat a balanced and varied diet when you're exercising. Of course, it's important to drink enough water, but I think, I talk about not smoking, trying to stay away from sugar, and it's a discussion. There are no diet studies in myositis, I think. If you would like to train your muscles, then you would want to get protein, but at the same time we know that red meat might not be the best option, but there are other ways to have protein in your diet, like chicken or fish or eggs. So there is no easy answer. I think it can differ from individual to individual. What do you say, Ingrid or Louise?
Yeah, I agree. We need, sorry, Ingrid.
Mm-hmm. No, I agree. We have no studies to base our recommendations on. I think we try to have a balance in the diet is important.
And follow just the recommendations, just as in the general population. That would be the same for patients with myositis.
Thank you very much for this answer. The next question. Do you suggest better to have indoor or outdoor physical activities when possible, and or also to alternate, of course, according to the weather conditions?
I'm not sure I heard the question.
You can see it in the chat.
Okay. Yeah.
Yeah, I think it's you, Helene, might be able to answer that question.
Maybe, Helene, please.
This is better to indoor, outdoor. I think for the results in physical fitness, I'm not sure it makes a difference if you do your training indoors or outdoors. However, if you struggle with severe fatigue, I think it might be a good option to be physically active outdoors, because you get more sunlight, perhaps daylight, fresh air. But ultimately, I think it's comes up to what you prefer to do. And of course, if it's crappy weather, I think it might be a lower threshold to do something indoors if you have availability for that.
Thank you very much for this answer. And I got one question. Is it good for patients when the disease is not in remission to exercise? Ingrid,
So
Helene,
there is muscle aches after exercising. I think if you experience more pain for a long time after your exercise, I think there is something, you need to do some changes in either the intensity or how long you're doing the exercise, to include some more resting. So I think it's different ways using these fit variables: frequency, intensity, time, and type. I think it's important that you don't have a recovery time like longer than 1 hour. to be able to sustain your exercise habits.
Thank you very much. The next question: if a patient with active myositis tells he has muscle aches after exercising and it is demotivated, which recommendation should you give?
I think that's a very good question. We are about to publish a qualitative study where we have interviewed patients about their pain experience, and several said that I need to take painkillers to be able to exercise. And usually they use like Tylenol, not a heavy painkiller. So I think when you're getting started and if you haven't exercised for a while and you need it to get going, maybe it's a good idea. But then in the long term, I think it's good if it's possible to adapt the training so that you don't need painkillers. What do you other think about this?
I wouldn't be that concerned about pain. And I think that it might be the most important answer to the patients, unless it's something really, it's quite severe, but it's pain in itself, as you just said before, Helene. It's not. I wouldn't have that much concern about it. I try to say that it's a sort of quality sign when you exercise. You do get pain but if it's too much, then you have to talk about how often and just what you said, the intensity, or could you try to break it into two, or maybe not every day. I think that would be too much if your disease is active. But Helene, she knows more about that. But I wouldn't. It's a common complaint, but that's a common complaint when you exercise, that you do get pain, and especially the day after. So it's the degree of pain. If it's really severe, of course, then you have to sort of decrease the intensity or the duration or how often. And
I think it depends on what quality of pain is. It is delayed muscle soreness, then it's good. And if you don't have it more than like for the next day, I think it's good to have that kind of muscle soreness. But if it's another type of pain, if you have severe pain along with your myositis, it might be another type of ache or stabbing or burning pain that you might have to manage in another way to be able to sustain your exercise.
May I also comment that some patients really have a higher CK after exercise, and you shouldn't worry about that.
No.
It will spontaneously go back.
Thank you very much for this answer. The next question: do you suggest painkillers moderate use before to start the exercise?
Not necessarily. Depends on the amount of pain and if it's possible to change the training program so that pain is not severe. I would suggest that.
Thank you very much. And there is the last question on QA. Do you have any information on supplementation with creatine in patients with inflammatory myopathies?
The creatine?
Yeah, creatine.
Yeah. So we have published a study, it's quite many years ago now, where it was a double-blinded randomized control trial where everyone exercised with a easy, moderate home exercise program. And one group got the real creatine powder equaling 5 grams per day. I think that is the amount of 3 kilos of meat daily. And the other group got a placebo powder to put in their morning drink. And the results show that the creatine supplement, creatine supplement group improved more in both muscle strength and muscle endurance compared to the ones who only exercised. And we are using this in Karolinska in patients who are exercising regularly, who are in a stable phase of their disease, but they have reached a plateau where they don't improve so much more with exercise. And then we've seen that they can, this can make a difference. So 3 months of creatine supplements every day, exercise at least twice a week, and then you rest for 4 weeks to preserve your kidneys and so on. Then you can start over with another 3 months. But it's crucial that you have a regular exercise habit. So it's no use taking them if you're not exercising.
Thank you very much. Maybe it was a last question. I see that time is over. I would like to thank all of you for Ingrid, Louise, Helene for extraordinary webinar with a lot of information. Thank you very much. And in 1 week, the webinar will be posted on the ER and Reconnect YouTube channel. Thank you very much. Thank you very much, all these participants and attendees who watched this video.
Thank you, Olga. And thank you, Louise and Helene.
Thank you.